and sometimes he's not speaking the truth, and sometimes the patient believes it's a human being, and sometimes the patient thinks that if they skip the protocol, they will be gaining more time or gaining more preference. But the patient sometimes is not aware of all the risks involved if the patient is not telling the truth, no? And the final affected person will be the patient. So therefore, it's important that the patient has the informed consent form, and that this is duly explained to the patient, that the information that the patient will be providing to me is confidential, that we will not be sharing with this, but it is of vital importance that the patient speaks the truth and gives a true information, because otherwise it's going to have an impact on the results. And sometimes in the waiting room there is a video or something while the patients are waiting or in the queue, then they are told about the importance of giving the proper identity document or identifying themselves correctly, answer correctly all the questions that are being made to the patient, and speak the truth, and especially to fill in all the questions. And so the patient must be aware that uh, about that that all this is for his own safety, you know. So therefore the patient must finally will help us to detect also any failures in the process. So therefore in this context, the we should always tell the patient to give all the information requested. Well, we have spoken a little more about that. It, it says that everything is here should be included. All the information request form, no, the request for information. I mean, sometimes the patient gets there only with the application for the test application. But if you have another record where you put in all the information of the patient, you need to record all the information, all the ID patient, the number of the physician. For example, that's important. Sometimes you get to the laboratory and you have the order of the doctor in the, no, that it says that the paper that it says that the physician, his telephone number and everything, and you record the data of the patient, and then you don't include that and you leave that space in blank. So therefore, it is important to work with the people at the reception desk to understand that all that information should be included. But but for example, if you're working with other laboratories, it's of great importance to work on raising awareness about the safety of the person. No, all the staff, especially a staff, not only laboratory but administrative staff, should be aware of that, of the safety of the patient. So therefore, it is important to include the doctor's name, the contact details, because when we do a notification on the results associated to critical or significant risks, the scale or the reporting scale should go related to the doctor, not to the patient. So therefore, we need to understand the risk and the test and the conditions present at that time. So therefore, it is important to have all the details of the patient contact, and the notification is always given to the patient or the authorized person. So therefore, it's always important to ask the patient that to whom shall they report the results in case of a need. No, the type of primary sample that is required, the requested exam, and the clinical information. For sometimes the standard does not give does not specify the information, but we should also give the clinically relevant information. What do we need to ask from the patient? Sometimes we need to ask the patient up to if he had done exercise before or any type of workout before getting there, or if he came walking or in a public transportation, or if he had smoking a cigarette before the test, and what was his last meal. So several things associated with that clinically relevant information, whether any exam has been conducted on the patient that requires contrast media, or any functional test has been conducted in the last 48 hours. So therefore, that clinically relevant information it's somehow remains open so that each organization will decide exactly what should be asked under that clinically relevant information. It's important also that we should facilitate things at the time of taking information for during the sample collection, because sometimes the patient does not want to fill in so many things. But really, we should not shorten the times or shorten the information because the patient will get upset. What we need to do is to try to make the best use of the time and make our work correctly with the patient. When, for example, when we see that the patient, the route of the patient throughout the process, we know that there are some critical moments of the patient, no, concerning with the healthcare professionals. And an important thing, especially one of the most important thing is precisely during the sample collection, because the delivery of results sometimes is not important to have the contact with the patient directly, but it's at the time that the patient gets for the sample collection, that's the best thing to get all the details, the date and the time of collection of the primary sample, and all that information can be in electronic or in printout or in paper. That depends on your type of work and how your organization is working. We need to have some very well documented guidelines concerning the verbal requests. For example, if somebody can go to your institution and say, well, I have these symptoms and where should I do this specific top test, or and I'm feeling like this, I need to take a sample, whether this can happen or not, and what happened in those cases, how these cases are managed, to see whether for example, in the cases that the patient appear voluntarily and they and requesting for a test and they accepted the conditions being offered. Probably in your case, this is not a frequent action, but in the case of users, sometimes in general laboratories or in state laboratories working in your country, there are cases like this that might occur. So therefore, we need to document all the procedures for taking and handling of primary samples. Here, it's our important point, the collection and handling of the primary sample, the documented procedure for taking and handling the primary samples. Look at this is very important. This procedure should be available for those responsible for carrying out this. So for example, whether or not they are a laboratory personnel. For example, if I'm the hospital staff, I have the procedures, I have it available for the entire staff, not only from the laboratory or from the hospital. But if I come from a reference laboratory, or if I come from the reference laboratory of any of the countries, really, what I do is to establish, to document this, and to make this known to all the laboratories in the network, to ask them to implement that procedure, and also to ask them to share with all the particular or private laboratories, because it's me that know exactly how to carry out this. You are the owners of the process. You are the ones that know how to carry out this guidance. So therefore, your procedure should be very user friendly so that they can reach all the laboratories, even to the smallest laboratory in the country. It's not that you are using it or it, but the important is that it should be made available to all the laboratories in the network, and especially that all of them should know how to do this correctly. Sometimes they are managing like restricted information and only for some specific. No, this is an open instruction, and we must be careful about this. When taking the samples, it is important that not only the instructions for a sample collection, but also what happens if in some cases these instructions cannot be met. For example, uh, the patient might tell us the difficulties that they had when taking the sample, so we can record if there was any difficulty, so we can know whether this will affect some of the prior requirements of the sample. So therefore, for example, if there were any problems during the transportation of the patient or the sample, sometimes it's much better to ask the patient to take the sample again instead of taking that sample that was not properly taken, because the one to be benefiting will be the patient, really, not us. So therefore, the important is that we should tell the patient, and so therefore we shall speak with the the only affected person will be the patient. So therefore, all of us in the laboratory will do the best as possible if the sample has not been correctly taken, but it's better to tell the patient to do this over. And well, here speaking about the informed consent, well, then it says instructions for the activities prior to the collection of the sample. For example, if for example, we need to stay to do this step by step. No, for example, if the patient arrives, no, you need to tell internally do this. Yeah, you should do this before taking the sample. You need to be sure about this. You should have all the instructions how to check the filling of the exam application, how to be sure that they are that the patient preparation is being included. We need to have a very clear all the requirements of the sample, the amount, the tube, the flask that's going to be used, the times of the process, the associated records, whether the record of the hour of the time, the exact time where the sample was taken, we need to put that on or not. So therefore, all that information needs to be already introduced, already included before taking the sample. Now comes the instruction for the sample collection, for the sampling activities. We might need to be very sure that the instructions that you have established and that are documented for sampling activities, first of all, that we need to be sure about the identity of the patient. And that's something that comes from the beginning, from the patient care stage. I can let me tell you a story that it happened to me really. One day, I was going to a workshop, a weekend spiritual workshop, and there was a girl in the workshop, and she was telling a story, and she said that I make him believe that I was pregnant. So then, and then I was with her, I was speaking with her, and I asked her, how can you make somebody believe that you are pregnant with so many months? And I don't understand. And they say, no, it was easy. I made a positive pregnancy test. But how did you get that positive pregnancy test? Please, somebody has the microphone open. We cannot listen. So therefore he said, no, no, it was very easy. I had a friend that she's pregnant, went to the laboratory and she said, and she gave my name. It's as simple as that. She gave my name and the test gave a positive result. I say, well, what happened here? So there are countries in which patients reach to the laboratories, good morning, my name is such and such, and they record that name. Fortunately, there are other countries where you get to the laboratories, you need to show your ID document. So if you are in this accreditation process, you need to take into account, you need to ensure the identity of the patient from the time the patient is recorded, is registered. And you need to ensure this at all different stages, because it happens that sometimes that they are replacing or they are replacing the identity, but sometimes it happens when for drug or things that it happens these topics, but it might happen maybe for a pregnancy test or for a glucose test. We do not know whether this will be used for an insurance policy or for any other requirement. So therefore, it's important to ensure the identity of the patient from the beginning. Then at the time of collecting the sample, we need to check once again the identity of the patient and to see that the patient himself is identifying, because it happens sometimes that you are doing something and I'm working on a computer and then somebody asks me and I say anything and I say yes, but you see, so therefore it's important. So sometimes the people are doing so many things that when we ask about something, they answer like automatically without thinking, and it's not doing this on purpose. Sometimes it happens that we are doing so many things at the same time. For example, we have a full waiting room, and you call somebody by his name, and he say, "Well, the X and X," and that person comes and say, "Is your name is Pepito?" And he says, "Yes," and we have not reconfirmed whether he is the person that I'm registering there. So therefore, it's important. Also, the another point that is important is the instructions for the samples, for the labeling, that they include all the names of the patient. For example, if a patient say sometimes if the patient has many names, we need to put all those names in the label of the sample. So therefore, we need to ensure the identity of the person. It's important. And you need to work that with your laboratories. And because I know this at first hand, that when the samples get to the organization, they come with the names because the laboratory that sent uh, had sent the things, and in the case of COVID, I think that that's when they put all this system. So for the National Reference Laboratory, when they start.
Lo único que estaban haciendo en los laboratorios era COVID. ¿Cómo llegan las
But
muestras
if you
mal?
just were doing COVID in the labs, how the samples came badly packaged or identified, well, that happened anyway, so that is important as well. You should also make sure that they meet all the pre-analytical requirements. Go again, ask, confirm. This is the moment of truth. Make sure that you know all the information, all the protocols, well, all the instruments and equipment, the tubes, the additive, the slides, whatever you need to take the sample at that point. You should also have clear instructions for the labeling so you adhere to them. You always leave record of the person taking the sample, the date, the time, guarantee, take very good care of the storage conditions before you take the samples to the lab. I don't know how does it work in your organizations or in the institutions that you work. I know that there are some very good models. There is an area in one, for example, that probably works very similar in all your institutions. They have a central area for reception of samples that receive all the labs for uh, all the samples for all the labs, and it's this whole challenge for them take care of this arrival of the data, the samples, full data. If every diagnosis that you do requires all this information, you must make sure that this arrives, and this is a fair filter. They, if there is any information missing, they will ask for that, and there are special tests that go directly to the other labs. Every lab will review the conditions in case this first filter they pass it, they go to a second filter, they have a third filter just in case they miss any information. You can see then how we can actually guarantee all these conditions in the process. So yes, we have to do it, and it is our responsibility to make sure that it is being complied with and provide the instructions so that everybody will do this correctly. Once this process has passed, it might be that the sample, while it gets you to the institution or to the lab, it might take 2, 3, 4, 5 hours. I don't know how many hours. In some cases, half an hour. In some cases, it arrives directly to the lab. It is important that in this time, while the samples will be processed, we make sure that they are maintained within adequate conditions. And we should make sure that the material used in the process, it's disposed of in the right manner based on the instructions provided. Then the transportation of the sample. Well, these, I think that for you, this might be probably of the things that you do the most. You probably have the documentation of the correct packaging and how do you guarantee in the whole process the security and safety of all the parts that participate and those who will be affected indirectly, the population. How do you manage this? How do you manage the contingencies? Someone was saying, and someone was asking in the information that you asked us to discuss here, someone mentioned that we should uh, talk about the reports and everything. And we cannot go in depth with regards to that for spills, I mean, but I can, the only thing I can tell you that is a spill is a contingency that can be secondary to an accident, the problem with the liquid. So have always as a contingency, have a protocol for taking care of the contingency in case of spills, where you will establish who should do what, and that you can verify then that you established was really done, that you can prove that you can run simulations even, or to guarantee that it works. And if something was not working, you would be able to correct it if you prove it and test it. So we should take into account the population in the process. Then we have the sample reception. Well, here, when the sample arrives to your institution, what are we going to review? First, we need to guarantee that we know who the sample belongs to, that it's complete with all the information and all of that. But besides, competent and authorized personnel should be reviewing this criteria for acceptance, because there are some organizations in which the secretary receives and says yes or no. So if we do not have another filter that can guarantee the technical competence of the person that is accepting or not the sample, then we will have a very high risk, a very, very significant risk, okay? When the sample, well, we have already discussed what happens with the sample is not compliant or it's irreplaceable, and how can we communicate to the other organization if that sample can be processed, if they have to send another one, and how can we talk to them to know what is the specific case. Sometimes in labs like your labs, when a patient, when a sample gets to you, it is because there is a long history behind or a great risk behind. There is an important complexity. The samples that come to you are important samples. So before deciding whether to accept or reject a sample, you have to talk to the lab that sent it to be able to be clear about that, to always think that behind there is a patient, there is a life, and we do not know what the complexity is, what is the need, the urgency, or what could happen, or what if sample arrived in these conditions. Usually it's the lab that should be notifying us, but sometimes they say, no, I sent it, and they will process it. So that's important as well, to have records of all the electronic entries, physical entries with the information that is relevant, minimum who receives at what time, in what date, who will send it, what is the sample that is received, who is the patient, the type of sample, the time it arrives, and then you can have everything that you consider adequate based on your system. And the urgent samples, well, what I was telling you, the urgent samples, having established the criteria, if I accept urgencies or not, and under what conditions, what is an urgency and what is not an urgency, and how do you manage this? And please understand that it doesn't matter how do you categorize your urgencies. The sample should never lose the condition of urgent in the whole process, because if you did everything urgent and in the delivery of results, you just stay in the desk for a while, you lost all the effort done by the organization, and besides, and even more, you affected the patient. So always guarantee that this urgency is followed in every one of the steps, no? So to make sure that it will get to the patient as a real urgency. Well, this we have already seen. And 5.747, everything related to same sample handling, preparation, and storage prior to analysis, guaranteeing always that I will maintain the samples in adequate conditions. Here, there is an important thing, and it is that the labs, sometimes they might, depending on the lab, of course, and depending on the samples, they might sort them to preserve them, right? And they say, no, I will process, and then I will dispose it off the next day or that same afternoon after they reported that there's no sample any longer. And that might be counterproducing in some places, so, or in some cases, better said. So we need to establish what is the time to retain samples, even though, well, here we're talking about the storage previous to the analysis. Then we will speak about the retention time. This is not the moment to talk about that. But well, here basically it is to establish whether it is possible that once I have the sample, I already have it, I had already processed it, or I have already reported, or during that time, if they can call me that for me to ask an additional test. If that would apply, you should let your users know how how do they how can they do this kind of request, and how long do they have. No, obviously that requires first a review. No, for this request of additional tests, you should to do an internal review by the lab, the process area, the process owner, so that this will guarantee me that the sample is there, is in the good conditions, and we can meet the request of the client. This obviously leaving everything documented in every case, who did it, what do they reviewed, when it was notified, and at what time, when did they say if the sample could be done, it could be used for another test, no? If this was possible in the process. Well, against the time, very rapidly, but this is what I wanted to share with you regarding this. I don't know, there might be some questions. Yes, Maribel. You have taken some extra time, minutes from your time, and we have a couple of questions. We will see if we can answer them all. This is a very important topic, and yes, it is a gap really that we can see in many countries with regards to not having the transport efficient sample transportation. That part of the time, the preservation, the safety, the biosafety, those are really some gaps that should be improved and that are always recommendations that we make when we visit the lab networks in different countries. And what you have said is very important. Well, Claudia very rapidly is asking, she says that in their case, they do surveillance for an event of interest. Probably she's mentioning surveillance of resistance as a reference lab. They do not receive the samples directly, but there is a culture done. She is asking if they need the informed consent for an event of interest for public health. No, in general terms, public health doesn't require informed consent for many things, right? But it depends really on what is the policy for informed consents in Colombia. The truth is that I'm not sure how it is, but I would think that no. Jorge Garcia says that the request for the procedures for the instructions for the request of exams that it's verbal, that would that apply when the patient needs additional tests? No, as I said, both things should be documented, the verbal request for additional tests and the initial request, both. The request applies in both cases. Jenny Balbuena, the standard says, or another unique identifier of the physician, provider of health services, or other person authorized for the request of the analysis or use of the clinical information. In our case, that would be the public health laboratory that will allow us to apply this. Yes, it applies for you. Yeah, it's the one that sends the samples, the public health laboratory. Tanya, sorry, just one more thing. Except in the cases in which you will have the information from the physician and because of an urgency, you might need information or any special notification. I think because of your level of hierarchy, you might be able to contact the physician directly if you need urgent information or if the information that you manage is very important for the physician, no? Because we might be endangering the life of the patient if we follow the whole communication path. Tanya Alas asked if it is valid to make reference to the quality manual that the indications for the sampling are described in the manual for the taking, handling, and sending of samples, which has been disseminated countrywide, or should be carry out a procedure assuming that in the national lab we do not take samples for TB. Well, the instructions for sampling from the approach of 1589, they should be documented, okay? The way in which you documented the name of the document can be different. You can call it a manual for sample taking or procedure for sample taking or instructions for taking samples. The way you call it, it doesn't matter. There are countries in which by the regulations, they need to have manuals for sample taking, and from the accreditation, if you show me the manual, that's okay. And in the quality manual, there is a very clear reference to the other procedures. Actually, the quality manual should and can and should make reference to this procedure. So yeah, that could be the reference. You don't need to document a procedure with your manual. That would be enough. Janelli Valbuena says, date and time of who takes the sample, in this case, sputum. Would the data will be provided by the patient when the patient conducts the procedure outside of the institutions necessarily? Is that true? Yeah, exactly. We asked the patient what time did he took the sample, and we asked the conditions under which he took the sample. Rosibel Cruz says that once I saw that they had registered twice the same patient because the names were similar, but in reality, these were two different people, and they realized because of the number of the ID document. That's why it's better to register the full name. Well, that reaffirms, that's what you have said, right? The errors in the names, this is frequent, yes. That's why you have to have these identifiers. Irina Ordóñez, how can we support on some aspect that that the standard mentions with regards to the incomplete data in the data entered into the lab, because there's always missing information. Can I reject a sample based on that, in the fact that I don't have enough information, and that's something allowed by the standard? That depends on the data that you have. Look, I don't know. Well, I suppose that it happens to you, but in a clinical lab, we have very frequently, when we are reference laboratories or outsourced labs, we have samples that come without complete information. And so you always say, it's because the labs, they sent us the sample without information, and people does the root cause analysis, corrective actions, and the problem continues, and continues. I have a theory, and I think that this happens because we continue allowing that. In some labs with which I worked many years ago, in which I worked and I was a director, we 1 month we stopped processing samples that were coming with incomplete data. So since they were coming with incomplete data, I told the lab, the sample is going to be rejected. We are going to send it back to you. And the lab, no, but I need it. Yes, but if you don't send the full, complete data, I cannot process your sample. So, okay, don't worry, we will take the cost, but we will send it back to you. No, stop, and I will send the information. And with that strategy, we reduce to 50% of incomplete data. So I believe that you should establish a policy, but especially you should comply with your own policy, because that's happened. If we tell them we do not accept, and they will do it, but if we say we don't accept, and if we accept them, they will continue doing the same, no? Because, and you can reject them if you want, because it is you that established the need for information. Of course, let's see if what information as well. If there is a data missing, but it's not really necessary, well, it might be. But if you really need, there's something missing that it's really important, you know. Well, we don't have further questions. Sorry, I have one more question here. Hi, Maribel. This is Yadira. In the National Institute of Health, we currently have around 10 accredited tests with the standard ISO 17025. The question is, we the importance of this pre-analytical phase becomes indispensable, and it's very important that in the mycobacterium lab we accredit also with this standard, with the 1589, or in some way or the other we can use what we already have, that it's been so difficult for us to get this certification with 17025. How could we do, you know, to use that standard only? Well, there are two things there. The thing is that it's not only for because of the pre-analytical 1599 apply by itself, because what you do, even though you do surveillance activities, you also do diagnostic activities, and there are patients involved. So the standard that applies is 17025. Now, if you have done a very robust work with 17025, yes, there are many things. I mean, everything that you have done will be useful for you for 15. Why? Because now the standard is under review, and 1599, I don't know when it will be released, but I know that the next version will be aligned to the structure of the top level structure of the ISO standard. So the structure between the one of the objectives of updating the standard is aligning to the structure to the structure of the other. So it's important to you that you accredit with 1589, but because it is a requirement, it is a compulsory requirement that has been set for the mycobacterium labs. And second, what you have done, it's not that you won't use it. Probably it will be very useful. Everything that you have done will be very useful for your new accreditation. And what you need to align is that the system and the documents are useful for both standards, and that whatever you do additionally, you will have to do additional things that are associated to all these, to clinical usefulness, patient security, interest, acceptance, and rejection, very clinical things that apply only to the mycobacterium, and these will be aligned with 17 and 15, so that when the new version is released, it won't be that difficult for you to comply with it. Okay, thank you very much. This concern was really mentioned during the first day. The first topic, I think that you didn't participate, but the first day, the first presentation, Roberto explained the differences between 1589 and 17025. And I have explained to you many times as well that for the TB labs, whether at the reference level and if they do not receive samples directly, if they are working in the from strains for the sensitivity test. And even it is a surveillance, the WHO has recommended that these labs are accredited under these standards. You can review the presentation of the first day, the presentations we had in the first day. So we will change in a minute. We will have 1 minute break. We are very close to our time. So we will have 1 minute and then Roberto will start with his presentations. Thank you very much. Ernesto, I'll use 30 seconds. We have been reviewing the photos that have been taken, and from the 100, 210 people that we have, we only have 30 cameras, around 30 cameras activated. So we have 30 pictures, and there's 6 people that have said that their cameras are not working. So I have sent an internal mail to these people to send a picture to me, but there are 60 people that have not opened their cameras and we only have their names. So I don't think that you don't have camera, because those who do not have camera have already mentioned that. But what about the others, please? Or you were not there at this point, or I don't know what has happened, but I think that at some other point we are going to take another photo, and please, when we tell, turn on your cameras, so we will have most of you. Otherwise, we will only have your name, and we always like to see people. So at a different time, we will ask you to turn on your camera, maybe later on after the break, to be able to take the photos again. Thank you. The people that do not have a camera, we are working with them to see how when we are going to put their photos, but when we check, it's like 60 cameras that were not opened. So once in the next break, we might ask you to take the photo. Thank you. Or it might be at the end of the session, Lourdes. Maybe at the end of the session, of course. Yes. Yes.
Damos paso a Roberto.
Okay, Roberto, you have the floor. Good afternoon. We will continue now with what we have. Just give me a second. I have a better audio signal right now. I will share my screen right now.
Ahí están viendo la presentación.
Okay, you see the presentation? No, not yet. Not yet. Something has happened. I don't know. Let me check.
Dice que ya has comenzado a compartir pantalla.
Ya, espérate, ahí. Voy a partir de nuevo. Que se había quedado pegado el
Okay,
Zoom.
there was a problem with the Zoom. I will share my screen now.
Es esta la pantalla que está. Esta también
Okay,
ahí ahora la
now
Se
can you
logra
see the?
poner la misma
Yes.
presentación.
Okay.
Sí, perfecto. Entonces yo voy a trasladar esto para
Okay,
ver qué es lo
I
que
will.
acomoda.
Okay, this is correct.
Entonces, va a modo presentación. Ahí estaríamos, ¿cierto?
Completo.
Okay.
Perfecto.
Puedes empezar.
Ajusto cronómetro y estamos listos. Ya, estamos en condiciones.
Okay. Okay, we start.
Ustedes me dicen.
Ya, puedes comenzar.
Yes, you can start
Pues bien,
right away.
vamos entonces. Y nos vamos a ir entonces hasta a la continuación de los requisitos de
We
la
will continue with the standard requirements, and now what we need to see
un poco más técnicos.
more technical processes right now, analytical processes, and in particular, topics related to the validation and verification of the methods. Here, we somehow need to tolerate ourselves, because you will realize that the standard has a natural trend towards quantitative method. So therefore, we need somehow to be separating and filtering the concepts, and somehow I have tried to make some like a parallel approach. So therefore, respecting with the suggestions textually made by the standards, which regarding the methods of a quantitative order or nature, and do a parallel analysis concerning the qualitative methods. So please be tolerant because we're going to be changing constantly. No, of course, we're going to be dealing with both the quantitative methods and qualitative methods, but let's bear with me. First of all, from the point of from the standard perspective, the standard clearly says that the exam procedures should be selected based on the intended use, and they should be validated according to that intended use. And that's the first relevant concept, which is the validation. It says, of course, that they need to have the proper record of the person carrying out the activities, but that's more of an administrative nature. But here, clearly, in the next paragraph, we see that the condition, the requirement is that the performance specification should be established for each test procedure. And this concept, which means the performance requirements, it's very close to qualitative, no, with something that is established as a qualitative method, which regarding to the quality requirements and is related to the total mistake of the or the uncertainty related to this qualitative aspect, no. So therefore, this part of the standard does not suit does not fit correctly with this qualitative aspects. It says that the preferable procedures or the preferred procedures are those specified in the instructions for use of the medical devices. For those, they need to be sure that they should be very well known analytical procedures that are published in established or authorized textbooks that have been reviewed by peers. All things that how you can be using these procedures. Remember that a while ago we spoke about the selection of the procedures, and also somehow we have relevant concepts related to the selection of an analysis procedure in both contexts has to do with the degree or the level of representation that it has, no? Or the representativeness that it has. For example, to the best possible, we need to consider that the level of, of, of representation has to be very broad. This needs to be a procedure that is commonly used because this process or this common aspect of the process, it's important, especially when we are carrying out an intercomparison test, and we hope that the analytical purpose is represented in this comparison test. And therefore that is not the only procedure that doesn't have where to be compared with. So therefore it's important that selection of procedure needs to take into account all these requirements. This needs to be procedures that are associated with a common use. It's commonly used and it's recognized by the scientific and international scopes, and also that it can be represented. It has a relevant representativeness concerning the other procedures that are available. So the first condition concerning the 15189 for procedures is that the processes should be selected as validated procedures. So the first semantic approach that needs to be considered here is, what do we mean by validation? And here we are entering in more technical topics. And it's important that we have at sight the definitions, the standard definitions. That's why I have included the international metrology vocabulary, the VIM, and because I'm trying to somehow to speak in a technical language that is recognized internationally. because on several occasions, and especially in presentations, in conferences, our language and the language of opinion makers are not technical languages in many cases. They are very colloquial languages. Even in the last chance, somebody said, I'm going to be speaking for the language that all my peers can understand. But it happens that it was not technical at all. So therefore, whether they mean maybe that their colleagues are not technicians. Let, so therefore, we need to be a little more fundamentalist and recognize that terminology is a mechanism to have to have the necessary scientific communication, because if everybody speaks as we want to do or colloquially, we are not going to be understanding between each other. Of course, we need to have a common language, and the common language, of course, is included in the standard communications, especially in the case of the VIM, the VIM, which is the International Metrology Vocabulary. This is available you can Google this and you can have access to this, the International Metrology Vocabulary. Okay, let's see the concept validation. What do we mean by validating? Sometimes these are a little difficult to understand sometimes. Let's what it say. Validate is to verify that the specified requirements are adequate for the intended use. So therefore, it's the verification that the specified requirements are adequate for the intended use. Well, it's not very clear. It's not a very clear definition, really. Verification. Well, the requirements of what? Of course, the requirements of the analytical process to verify that the requirements of an analytical procedure are adequate for the intended use. And what do we mean by the intended use? The intended use is for the target or the public that we want to use these requirements. In here, the concept of validation is mainly restricted to the person that is designing a procedure, or those that are designing or structuring an analytical procedure, because they are the ones that decide what requirements should be met and for what purpose, for what intended use. That's the freedom of the validation, or the openness of the validation concept. Validation, we need to see, usually this definition is given by the person that is designing the analytical process and has the freedom to decide according to the intended use what specific requirements should be met. And here we're speaking about specific requirements or for maybe performance requirements, the veracity, traceability, the lack of interference, and so on. So therefore, it's the person that is designing the analytical procedure is the person that will be defining what are the specified requirements and what values they have in order to meet and to be adequate for an intended purpose. So therefore, what is our problem in this case? Our problem as users of a procedure that has already been validated is that we need to be sure that that validation, that the specified requirements and the intended use for which it was validated are the ones that we actually need. And sometimes this is not true. This is not the case. When validation was made by somebody else. Now, if we ourselves, if we validate, this means that we will establish the performance conditions. We will establish then the specified requirements, and we will decide whether those requirements, according to the performance parameters, fully meet the intended use that we want to give to this particular validation of this process. This is very important to consider, because we're going to be speaking then of a parallel process, which is the verification process. And usually there is some confusion between these two terms, and the qualitative aspects, even there are even more confusion. The scientific community does not cooperate so much concerning the qualitative. Um, in the quantitative scope, the terms are very clear, but concerning the qualitative aspects, then things are not so clear. So it means that we, first of all, we need to lay the prior foundations of this concept. What does the standard says concerning validated procedures? If if the laboratory validates, the laboratory may obtain these from the following sources. I can obtain validated procedures from the following sources. No, first of all, if the laboratory validates, to whom it should validate? It should, what they should validate? It should validate non-standardized methods. This comes from the language of the standard 17025. This is not our own language. It comes from the standard 17025 because we do not apply these non-standard methods or non-standardized method. Or non-normative method. These are analytical processes that have been published and have some sort, they have some legal foundations. For example, there is a standard methods to measure lead in blood when that measurement is applied to labor or occupational medicine, because we need to see if there is any trace of intoxication. And so therefore that procedure is part of a law. But that's a very particular case that it's we in general in the clinical environment, we do not use this normative concept. Now, when should this be validated? When we are speaking about in-house methods, no? In-house methods or methods designed or developed by the laboratory, they should be validated. When we should validate the procedures? When we use a standard methods outside its intended scope. For example, what better approaches to this concept of standard, it's, it's, it's a commercial method. Because a commercial method is validated. But we're going to visit that later on. What also we need to validate when a standard method is used outside its intended scope. What do we mean by that? Well, for example, that method says that this is used for serum and plasma. Well, but I'm going to be using it in encephalorhynchian fluid and in urine. It's the same? No, it's not the same. If I uh, do not meet the use condition considering the parameters and characteristics of the validation, although the method has been validated previously, but if I breach that, this needs to be validated in this new condition because the former condition is not valid anymore. So in practice, that's a relevant inconvenience. Well, we are very good at making all sorts of amendments and changes to the laws or to the procedures. Sometimes we like to change the reagents to take this or from that. No, gentlemen and ladies, in concerning accreditation practices and strict validation, this is not allowed. Everything can be done, but it should not be done. Technically, it should not be done. Therefore, under what other conditions can we validate? And in the case of a validated method has been modified. For example, if we modify or we use a validated method and it's modified, for example, if we change the proportion of the volume in order to maybe to have a better yield, or do we change the incubation condition because it's maybe just only we shorten the time of incubation? If we interfere the intended use conditions that are specified in the validation practice, then we will lose the validation concept. So therefore, in order to continue using that procedure, we need to validate it again. And I want to be very clear about this, because we usually like to modify things individually. And I think that those modifications have no impact on many occasions, because we do not do sufficient tests to prove that there is no impact in the results. So therefore, there we have an important aspect. So therefore, the question will be who validates? Who will validate? And here we need to somehow put our um, work in order. Who validates? The manufacturer will validate.
Que un fabricante reconocido con el marcaje FDA Approved o
Therefore,
reconocido.
I expect that a manufacturer recognized with FDA or CE markings, which are the two large mechanisms for the registration of diagnostic mechanisms for our sector, is the one that has validated based on the requirements for validation that demand the CE marking or the FDA one. Therefore, a commercial reagent, a commercial kit will come, if it comes recognized by any of these two origins or markings, it's validated and meets the highest standards regarding to the standards associated to validation. Do you understand? And there is an issue here. If you're interested in this, for example, you can go to the European guidelines, which stand with 9879 in the European Union with regards to the concept of in vitro diagnosis reagent. This is a very, very interesting topic that it's part of the history of diagnosis that started with the problem of the AIDS epidemics, and in the last 20 years it's something that has changed radically. It's one of the most relevant advances made in the concept of the diagnosis industry. That's how it is considered. And for many people, this is absolutely and completely unknown. We do not know the history of our activity. Therefore, the challenges, no, go and look for these guidelines, 9879 guideline. That's how the problem started, but this is not the moment to talk about that. No? Now, the responsibilities of validation, the manufacturer. When we buy a kit, a commercial kit. In the lab, when we develop, when the laboratory develops the diagnostic kit, even if it is copied from a publication, from a paper, even if it is copied and reproduced from a paper, the lab has to validate it on site, has to do this on-site validation. And besides that, when the laboratory uses a commercial diagnostic kit that it's validated, but they modify it, the validation is no longer applicable in that case if it's modified. Therefore, what does this mean? Well, this means that for us, what is the evidence of validation for us? The evidence of a validation is within the insert of the diagnostic kit, the insert, the documentation that accompanies the kit that indicates and mentions all the characteristics. That is the evidence of validation. And that document is regulated. There is a specific regulation that indicates what it should contain, at what information it should contain and convey with regards to the performance parameters, hey, which characterize, that's how it says, characterize this reagent and justify their use, right? That's where the key is. Now, if I modify this, I want to do it as the insert tells me. I have breaking the validation characteristics that I have. Therefore, I should have to validate it by myself. And that is not convenient for me because it's lengthy and expensive. And probably I might not know how to do it. Therefore, under any circumstance, I should modify in its use a commercial diagnostic kit that has already been validated. It's crystal clear. And now And we have already seen this. And what if that same diagnostic kit that comes from serum and plasma, use it in urine without that being authorized as part of the validation? I also have to validate it on my own. I have to do it. I have to pay for that. And these are actually the limitations, the specific limitations with regards to the concept of who has the responsibility vis-a-vis what acts. For us, you can see the manufacturer is responsible for the validation. Where do they provide us with the evidence of validation? In the insert. All the information is there. If I buy that diagnostic kit and I use it without modifications, I don't have any inconvenience, and I will execute just the following stage, the next stage, which is the verification in my lab. That's all I need to do. But if I buy this diagnostic kit and I decide to modify it in substantial aspects, for example, volumetry, or I don't know, in aspects related to the matrix, for example, no, as if that was that I do, obviously the validation of the manufacturer doesn't have value any longer, and the validation becomes a responsibility of the laboratory that decided to make these changes. Crystal clear. Crystal clear. Better? Okay. So what else does it say about validation 1599? Well, it says that in practice, this validation should be as extensive as necessary in order to confirm through objective evidence data. Data of what? Of the performance characteristics, that is data on what? On accuracy, precision, repeatability, intermediate detection, detection limit, interference, quantification limits, whatever you want to do. But everything that could apply to that aspect that justifies its use, right? So the validation says the standard should be sufficiently extensive as necessary and confirmed through the contribution of objective evidence in the characteristics, forms, and performance that the requirements is specified. That's what I ask. No, I want this linearity. I want this detection limit. I need this maximum accuracy. I need this truthfulness. I want it to be free of these interferences. So how I want it, the idea is that they meet the expected objective of that, no, to do what I want it for. And that needs to be documented. Whoever does this, if it is done by the manufacturer, all of that comes in the insert, and it is me who will decide if that diagnostic kit meets what what I need for what I want to use it, if it meets all these things. So that's very important. It's our professional responsibility. All these cases in which the head of the lab says, hey, I bought this and it cost me a lot of money, but there's no use in this, but I wanted it to give it this result to me, and it doesn't measure that, and I wanted it to give me low values, but in pediatric populations. But you should have read and find out that before you bought this kit. This is not responsibility of the manufacturer. Excuse me. What do I want it for? Not necessarily fits or matches what the manufacturer did. So I would need to look for a manufacturer that it's closer or has something adequate for my needs. And that means a previous selection process, that it's before. Okay, so you can see that it is not as linear as we wish it could be, and it necessarily requires from the users, that is from us, the users, the lab users, the lab professionals, it requires study and it requires decision. We make decisions, yes, of course. Now, what is validated in a quantitative procedure? Well, the standard parameters, performance parameters. You can see which ones. I'll just give you some of them here. I validate accuracy, I value precision, repeatability, intermediate precision, the measurement uncertainty, the analytical specificity, the interference, the sensitivity, the detection limit, the quantification limit, the measurement range, and I can go on and go on and go on, right? That's what we need to validate according to the textbook. Now, some of these parameters or performance might have higher or lower relevance based on my unforeseen factors, based on what I want this test for. But this would be absolutely specified within the conditions for validation, okay? Now, and how do I validate? Well, I do validate with the state of the art. Here is when I started being a little bit more incisive. I validate with guides of recognized professional prestige. I support myself in reference that tell me in what way I need to execute the experimental tests. The validation process is absolutely and completely experimental. Therefore, all the evidence that appears in the insert is experimental evidence that must have been described and executed according to certain parameters or recognizable guides at the level of the state of the art, of course. And besides, this management of the data many times requires the application of analytical techniques or statistical techniques. And it is here where I want to mention, I do not validate either as I think I should do, if I wanted to do it, of course, right? Therefore, I will try to first learn how the manufacturer did it. What guide did he or she use for the obtention of the accuracy or precision parameter? Usually, the diagnostic manufacturers will go to the guides that we recognize as the most prestigious guides in the in our environment, the CLCI. And this has guides focus on the manufacturer and some others focus on the lab. Mainly with regards to what? With regards to the numbers of samples that should be used in the conditions to obtain precision in a validation or precision in some other conditions that are not that rigorous. For example, but their standards, like ISO standards associated, for example, to the quality of the traceable materials for calibration, the materials for the reference materials, certified materials, normal quantitative techniques, enzymatic activity techniques. So there is a whole world behind this huge amount of scientific development that it's just something that we receive in a little box and what we call a diagnostic kit, and that it comes together with an insert. Well, now I insist. The concept of validating is situated or located originally in the manufacturer and in the lab, in the extent that the lab will determine if its own method for analysis. In the case the labs determine this, it must meet the same requirements as a manufacturer and follow the guidelines in which the validation process is recognized in an accreditation process as valid. And what I have just said is very important, actually. It has to go to guidelines in which that in an accreditation process, that validation will be recognized as valid. Because we have had cases in which the analysis of a process validated in the lab has been rejected in an accreditation process precisely. Why? Because or it is not referred or they just considered it too weak. When I say referred, it is not, that means that it is not related to guides or guidelines, or they have not followed the characteristics described in the literature considered as a state of the art. Now, and what happens in the qualitative part? What do I validate? Well, I validate performance parameters, sensitivity, specificity, false positive rate, false negative rate. For some qualitatives that have a quantitative phase that it's hidden, like the cutoff techniques, I also, in that case, I will also validate precision, detection limit. I will validate the relationship between the interval, the C60, 50, 95, and then I calculate the uncertainty in that interval. So these are techniques, definitely qualitative techniques, but in the case of the cutoff techniques, these are techniques that have an SCO, that it's intermediate quantitative as well. Therefore, the issue becomes pretty complex here. And where do I need to go? Well, you have to go to the guide. Usually the validation for qualitative, most of everything is in LP12 in this guide. LP12A2, which so far is the most complete guideline for this concept. Look, that even when I'm not going to, well, we will see the guide later on, but here there's things that are not that clear. Okay, but I make precision, and the precision for the cutoff techniques, which are qualitative, but which have that quantitative phase involved, this is done through LP15, which is a guideline for the verification, in the case of verification, exclusively for quantitative techniques. So things become a little bit more mixed in here. So now what happens? I go to the documents, okay? I will have to go to the documents, and here I want to show you that there are documents that you can go to. This document is hugely important. It's a Mexican document. It's one of the few documents that gives you limits. I will mention it later on, and that's why I put it here, because it's very interesting now. There are some other guidelines from other places of the world, for example, for certain groups of techniques that affect, we could say, some specific opinion groups, like UK has its own standards, no? The UK standards in the National Health Centers from the UK. There are guidelines for the CLCI explicitly described for methods, molecular methods, okay, with all their characteristics. And here, we don't know if this applies for validation, for verification, for what? Things become kind of mixed here, right? There are some guides that have been described in the microbiology, clinical microbiology review, like validation of molecular methods, for example, for infectious disease, validation, right? Can you see? But there are also French guidelines by medical biology, and in the qualitative part, there are guidelines as well, LP12, the famous one. But the EP12 says evaluation protocol for the test performance. It doesn't say if it is to validate or to verify EP12, okay? There is a certain ambiguity still in the concepts. When you read this, you will clearly notice where it is going to, but the title doesn't indicate that well. Different from others, like the EP15 guide used for quantitative methods for verification, which explicitly indicates verification guideline. Okay, but let's go now to the concept. Finally, let's finish with validation here. The lab says, well, the guideline, the standard says it must document the process using validation and record the results obtained. And the personnel with authority should review the results and record the review. And this is why it is done like this, because that's the evidence of having authorized a method that has been validated in the lab and which will be used in the laboratory under the authorization of the top management of the lab. Now, and when we make changes in a validated procedure, we not need to document the effect of these changes. And the same 1589 says, and when applicable, you should conduct a new validation. I mean, the validation is in some way or the other a definition of certain characteristics that should be maintained unchanged in the use. Okay, let's finish with validation now, and let's get into verification now. And what is verification? Well, verification says that according to the standard, it indicates that the procedures of validated examination procedures used without modification must undergo an independent verification by the laboratory before being introduced into routine use. I mean, we start now that the procedure has already been validated. We said a commercial procedure comes validated. Very well then, we bring it to our lab. And the standard tells me what? That this validated procedure in my lab has to go through a different treatment, which is a verification before being introduced into routine use, okay? So in practice, And what does the standard says? The lab says the lab must obtain information from the manufacturer or whoever developed the method to confirm the performance characteristics of the procedure. Very well then. So where are the characteristics, the performance or functioning characteristics? In the insert. When the procedure is commercial, it comes validated, and it's been validated in line with the FDA criteria or in line with the CIS, CLSSI criteria, which are equivalent really. So here we have the CE criteria, sorry, which are equivalent. So I have the validation, the criteria there that I must have to validate the verification. Now, what is verification? Let's go to the point again. The verification says obtention of objective evidence that an element satisfies the specified requirement. So these definitions, you have to read them again. Obtention of objective evidence that an element satisfies or meets the specified requirements. Okay, very well then, but look at this explanation that we see a little beyond. It says the following: verification is evaluating the performance of the method to demonstrate that it meets the requirements for the expected use that were specified as a result of the validation.
Ya. Entonces,
Okay. So what do I do when I verify? When I verify, I check experimentally that some parameters of the validation can be reproduced or replicated in the laboratory to ensure that the validated method has been properly adjusted to my staff, to my laboratory, to my equipment, and that can be used according to the intended purpose. Therefore, what does the standard says? Verification, independent verification by the laboratory must confirm through obtaining objective evidence, which is experimental data, in the form of performance characteristics as applicable, no, whether the precision or other characteristics that apply. So therefore, they must confirm that the performance characteristics for the examination procedures are met in my laboratory. So therefore, the verification process is a local process carried out in my laboratory that has as purpose to confirm that I am capable of replicating certain performance parameters that the manufacturer has delivered to me as part of the validation. Therefore, now, which are these? I will not be confirming all the parameters of the validation. I will be confirming, as the standard says, those that are pertinent to the intended use. So therefore, I'm going to be confirming only some of them. I'm not going to be doing a validation of all the parameters. I'm going to confirm those parameters that are relevant to the intended use of the test results. So in practice, the laboratory also must document the procedure that they have used. They need to document this as well, whether they like it or not, and they need to verify it as well. They need to verify it with experimental data, saying that we were capable of replicating the analytical procedure under the conditions in my laboratory and to obtain performance parameters that somehow are comparable to those indicated by the manufacturer and that are the result of the validation. Well, we're going to stop here. We're going to stop here, a small break. Yes, Roberto, as you see, this topic has been proposed by a considerable number of countries that were repeating this due to the need of the confusion, because sometimes the quality departments of the institutions, when the tuberculosis laboratory was undergoing all this accreditation process, they were demanding or they were requiring. I consider myself as part of that process. They were requiring that a validation should be performed, but a validation of a method that I told them it was a method, it was a commercial method that has been approved by the FDA, that was recommended by WHO, that was supported by all the manuals and political guidelines with great studies, all the documentation behind that. So therefore I told them, this has already been validated. So as you have mentioned, is not only to, it was not to validate, but to verify. And for the verification, I can speak about the lateral chromatography test or the sensitivity MGT test. I told them that the WHO, according to the supranational network of laboratories, they sent every year a panel to study the efficiency of quality of 30 strains of the TB microbacteria, and this has been already standardized. So therefore, these 30 strains were used in the sensitivity tests or in the dermidity test, and we obtained the results, and based on that we calculated sensitivity, specificity, effectiveness, uh, 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 and predictive, positive and negative predictive values. And this is something that is evaluated every year by the WHO with all the supranational laboratories of the region. So therefore, I think that that's a very important confusion, because we know that some laboratories of the region, in spite of the fact that they are using these methods, they're still doing verification. So I think that there are some questions here that somehow summarize this. In the case of Alberto, it says, of course, if we want to introduce a technique recommended by the WHO is something that I was speaking, should we also, that technique that has been supported by the WHO, should we validate it? No, the first thing that we need to verify is whether this it has been accepted. No, this is an example. It is a commercial technique. It is a commercial technique. No, if it is commercial, if it is available in the market, then it only would be necessary to make an on-site verification, not validate, because the technique has already been validated. Now, the thing is that the concept of recommendation, but per se is not a technical concept. Okay, whenever it is said recommended by the WHO, it has nothing to do with the technical part. It's just a recommendation. I assume that the study of the WHO will say, well, we think that this is inadequate, but this is not a technical argument to decide whether, based on that concept, I should authorize or not that technique. I think that technically I should meet the protocol. We're gonna see that later on, how we prepare a verification protocol. In the case of WHO, when they are recommending, at least during the past 10 years that I remember or more, when they are recommending a technique, is because it meets all those characteristics. Yes, of course, but I insist, this is an additional certainty, that this does not involve the technical assurance. They do not guarantee that this will work in the laboratory. Yes, they need to be a process of verification. Okay, they say, okay, you can select from this and that, but this has nothing to do with authorizing technically from an experimental phase in order to ensure that it does work in the laboratory. No, maybe I'm not using the so technical terms. Another example, for example, there is a technique, lateral immunochromatography, that it's marketed by Belton Dickinson. They recommend that in order to identify the TB complex based on cultures, they recommend that this should be done from liquid culture. They do not recommend that this should be done from solid cultures. Now, if I want to use this in a laboratory for solid cultures, in that case, I need to do a validation, because they have made a modification to the product. Exactly, yes. That's what I meant. That's correctly, perfectly correct. And that validation, as the standard says, should be very, very thorough and comprehensive, so that you are fully convinced that there are no changes regarding the method. because otherwise I will have another problem there, you
Por
see.
acá Zuli está comentando que
Where
tiene una
Sully
página
is
web
telling that,
que fue
that
diseñada
they
en un
have a
laboratorio
molecular
fue
test
diseñada en
that
este
was
laboratorio
designed in
para
the
para
laboratory
proceder a
to
partir de la muestra A y B.
to
Sin
process
embargo,
from
hay
samples A
investigaciones y
and B.
recomendaciones de la
However,
OMS
there are investigations and
basadas en
recommendations by
evidencia que dicen
WHO
que
that are
también
based on evidence
funciona
that
para
they also tell me that
la
these
muestra C.
also work for
¿Qué
the
uno
sample
debe hacer?
C.
Validar
What should I do? Should I
molécula
validate?
más idónea.
The recommendation is just to provide some
Eso es lo otro
guidance.
también,
It's
Roberto.
a
Sabemos que
guidance.
hay países
Yes.
que ya
Sometimes,
es
Roberto,
un
we see
proceso
countries
de
that they
validación y
need to
demoran
do a
años y entonces
validation process and
deben
it
de,
takes
como es
many,
un nuevo
many
proceso,
years
deben de incluir un
because
número muy
they
grande
must
de muestras
include
las
a
cuales
very
evaluar.
large number of
Entonces,
samples and sometimes it's very difficult to collect those samples. Yes. Later on, we're gonna we're gonna see the topic on the number of samples according to the process, according to the PE12. And I have selected a table that I would like to share with you at the end of the presentation, how to set the relationship between the number of samples and their importance at the time of analyzing the parameters.
¿Cuántas muestras son las
She has asked the
necesarias para
same. So
realizar algún
she's
proceso de
asking how
validación?
many
¿Cómo
samples are
tomar esas
necessary for the
recomendaciones de la
validation
OMS?
process
En
and how
caso
can
sí, de
this
la
be
muestra A,
according to the
debería haber un
suggestions of
procedimiento
the
de
WHO. According to
verificación
sample A, it
solamente
should
del
be
número de
a
muestras
verification
validadas.
process. Yes,
Por
you
acá
have already
preguntan, ¿lo
spoken
mismo
about the
procedimiento de
number of
validación que
samples.
estandarización?
William Roos asked whether it is the same
¿Cuál es la diferencia?
validation than standardization. If not, what is the difference? No, I think that standardization is understood as a global process in terms of general process, and validation is a specified process for a particular analytical process. It's an
También Sully
analytical
comenta de tener
process.
en cuenta que si el
Sully
tipo
also
de
says
sample
that we need to
también
take
cambia,
into
se debe
account that if
validar
the
la
kind of
variación,
sample
como
is
indicaba
changed,
hoy.
we need to validate. Yes, that's correct. Yes, if the matrix changes, of
Le
course, we need to
Supranacional de
validate.
México si tienen alguna experiencia para
In
validar
Mexico, they
moléculas
ask whether they have
moleculares
experience to
in-house
validate
para
molecular
detectar resistencia y
in-house
efectividad en
molecular
fármacos como
methods
apoyo
to
para
see
interpretar
resistance
pruebas de
to
sensibilidad
drugs
o en medios
concerning the
en medios
sensitivity
líquidos
tests
invalidadas o con vigilancia de
in
la
liquid
oficina de moléculas.
media.
Ellos están hablando,
Well, they, no,
claro,
I cannot give opinion
pero
when
están
they're speaking
diciendo que hay
about
una
specific
validación
drugs
porque están
or
ellos
riboflexin.
hablando de un método molecular
They are
in-house.
speaking about an in-house molecular method.
Sí.
Yes, I might ask if they have any
Para un
experience on that.
proceso de acreditación
For an
siempre
accreditation
se debe
process,
verificar la
we
validación.
always
Esto
need to
reporta en los
verify
documentos
and
que piden
validate
como
as
método de arrancar
applicable. That's what we are
el
asked at the
proceso de
time
acreditación. No se
of
puede
starting
dejar
the
eso porque, claro,
accreditation
se va a
process. We
corresponder con
cannot
una
skip that.
validación del
Yes, of
método que
course.
se quiere acreditar o
Whether
una
it's a
verificación,
validation
como ya
of the
en
method
este
that needs
caso
to be
tú estás
accredited or a
hablando de eso y puse
verification.
claramente el ejemplo del
I think
expert
that
Lisandro en Chile y en
I put
otros más
the
que sé que
example of the
hacen en
expert
algún momento un
that
proceso
that
de
that you
validación.
that I think that
No
sometimes
creo
you
que
were
porque es el
speaking
caso de
about a
realizar una prueba
validation process.
eh,
This is a
comercial, una
this
prueba
is a commercial
comercial,
test.
validada.
Ernesto, I think we're going to make a subtle difference in that case because there is somehow a gray area between validation and verification in terms of qualitative aspects. So therefore, this I'm going to be clarifying
La
this.
mayoría de las que se utilizan para el
The
diagnóstico de
majority of
validación son
techniques used for
cuantitativas.
the TB diagnosis are qualitative. Yes, but there are qualitative techniques that can be verified with great transparency and other qualitative techniques that sometimes there is some doubts whether they shall apply or not. So we're going to get to that point later on this morning.
Están diciendo por acá, Jaime Rodríguez
Here they
dice
are
que las
saying
herramientas
that
estadísticas para validación se
statistics
utilizan en el
tool
laboratorio. Ya eso sabemos que
workshop for validation, it would be
ni
of
está
great
ayer ni lo
help.
tenemos
But of course,
contemplado.
this is not
Pero
part of
quizás
this
sería
workshop, and we
interesante que
have not
puedan
considered
proponer
this.
eso
Maybe
si les
you can
parece.
propose this
Por acá
in your own countries. Denise
sí se dice que
from
las pruebas
Haiti
aprobadas
says,
por
it says
OMS
that the
no necesariamente
tests
requieren
approved by
validación. En
WHO do
este
not
caso, una
necessarily require
verificación es
validation.
suficiente
In some
y
cases, a verification
está
is
hablando de la
sufficient.
prueba
And
de
they are
liporabino
speaking
banano de
about
flujo
the
lateral de
liporavin
orina, así que
of the
también es
lateral
algo
flow
comercial
in
aprobado
urine,
y recomendado
that
por la OMS.
this is something that has been approved and recommended by WHO. As I said, the concept of recommendation is like a guidance. It's not invalidating the need of verifying at least whether the recommendation is commercial or not, or whether this is a proposal of a technique to be implemented and then validated.
Una última pregunta.
One last question.
Ordóñez, ¿qué experiencia tiene
Irina
con
Oroñez, what's your experience with regard to verification when the results are only qualitative? And an example of that. Well, you said that you were going to be speaking about that. No, let's not get into these individual determinations. I do not have the expertise on specific techniques in your area. So, well, these are the questions. Because we know that this is a topic of great interest and there is a lot of doubts. So we have just 1 minute, 2 minutes, 2 minutes more and we will continue.
Roberto, disculpa, antes de comenzar, ¿Maribel está conectada?
Excuse me, before we start, Maribel is connected. Do we have Maribel connected?
Para hacerle una pregunta.
To ask her a
Roberto,
question.
no se te escucha, no tienes los audífonos puestos.
Roberto, we cannot hear you. You're muted.
Maribel aparece en la lista de participantes.
Here I am.
Lo que quiero es si está conectado ahora mismo.
Okay.
No veo a,
I don't see.
Aquí estoy.
Here I am. Oh, Maribel.
Sí, te mandé un mensaje por email, Maribel, por favor.
Sí,
I sent you a
señor.
message.
Ok, gracias.
Tengo un momentico para contestarla o al final.
No, al final, al final.
Now, should I answer it now or at the end? I'll write down to you.
Roberto.
Thank you, Roberto. Let's continue.
Ya, ¿ahí me están viendo?
Sí, se ve.
Can you see me? Yes, we can see you.
Un minuto. Ahora sí, ¿ahí me están viendo
Now,
bien?
can you see this?
Entonces, retomemos el tema de la verificación.
Okay, let's go back to verification then.
Esenciales de la verificación.
Essential characteristics of verification. Well, a experimental process conducted in the lab. It has as a basis and a support the validation data. Therefore, the verification happens in the cases in which there was a previous validation, and we have this data from the validation. We have them available. And based on what? What type of data? Performance characteristics, parameters, on parameters of the methodology associated to the procedure, quantitative or qualitative. And some of these parameters expressed in the documentation that joins the validation, that we will try it and test it on site in our labs, and we will document all that. So it is important that it is clear. And here I would like to mention this. This is where we might not be sufficiently clear, okay? In the quantitative part, it is very obvious what we will see now. Look, in the quantitative part, what do I verify? Okay, I verify the error mainly based on precision, veracity, some aspects related to linearity, sometimes upper limit, depending on the technique, reference intervals. You can see here that from the number of performance parameters that are inserted into the validation, I only verify a few of them. I had around 10 or 12, and I see here just of them. I'm verifying just some of them, those that are interesting for me, the operational ones. The authors and opinion leaders do not agree with regards to what? For example, PL15, CLCSI, they just take into account precision and veracity. That's the only thing that they take into account, and they leave an open possibility for linearity, lower limit, and reference range as well. Okay, great. I'm talking now about the quantitative phase, okay? Now, how do I do it? I do this through experimental tests, okay, that tend to prove that I am capable of reproducing values for these performance parameters that come informed from the one who validated, in this case, the manufacturer, and they are in the insert, okay? Okay, very well. So what do I use as a support or as a basis? I have to support myself in the qualitative part, for example. I should verify precision. You would say precision, but in a qualitative, yes. What happens is that the qualitatives that have this quantitative phase, like for example, the cutoff techniques, yes, we estimate that we need to evaluate the precision of the SCU, the reason. That's why those techniques acquire, we could say, a characteristic, its own characteristics of validation or verification. Even though they are qualitative, they include a quantitative fraction. It's not exactly the techniques that you're interested about. I think that you don't have cutoff techniques applied to this, I think. So precision, diagnostic sensitivity, diagnostic specificity, predictive values, no more than that, what we should verify. But how do we verify this? Well, also experimentally. But please remember one thing here. What do I need in order to verify? Verify means prove that I am capable of reproducing the value of a performance parameter estimated in the validation, that is, that it's already there. Therefore, if I have techniques that have been validated, but that are not for which I don't have identifiable parameters to prove. That's where we have this area that it's kind of dark, kind of difficult, right? Therefore, maybe the relationship between validation and verification for exclusively qualitative techniques might end up being a little bit confusing, and that can be explained because I have to decide exactly what I want to prove, what I want to confirm with the validation. And in some way or the other, I need to adapt to verifying aspects that are not that clearly specified, like in the case of a quantitative technique. But let's see a couple of examples and let's go a little bit beyond this. So what I am based on documentation. First of all, of course, the documentation that I have available. Why is this important, and why I mentioned for the second time this work, validation of non-quantitative analytical methods from Mexico? Well, I mentioned this because very rarely the work mention limits, and they clarify what should I have, what should I obtain in the case of validation, and also in the case of a verification. And this is one of the few works in which these values are clear. Generally, the other publications, they indicate you decide, and that's where we have the problem. How do I know what to decide or what to decide? There's another very interesting job, or very particular one, which has to do for the clinical literature. And here it says, it mentions verification and validation of clinical virology tests. And this work in particular has a lot to do with our work. It works a lot the concept of a rare sample, difficult to get, as samples with a diagnostic accuracy, right? That have very specific. So it's a very interesting piece of work. It's not new. It's from 2007, but it's very interesting because it opened a gap then. So how can we verify? Now we are using, since 2010, 20 something ahead, we are using the term verification has already settled, so to say. 10 years ago, we had large, serious discussions on what was the difference. It was not that clear. For example, another very important job that it's important as well as validation and verification of molecular tests. So here you have to start looking, and you professionals, you have to start investigating in the literature where are the limits of your techniques, in particular, the limits between validating and verifying, which are already starting to be reason for publication, so the topics for publications, but they are already talking about that, and that's very important. For example, verification of molecular techniques, real time. Here, very clear, we are going to verify. So you can see, right? Not everything is said. This information is relatively new. It's just starting, like NATA, the Australians and New Zealanders. They have this guide for validation and verification of quantitative and qualitative tests. It's spectacular, and a spectacular guide. It's very good, very clear, and it's relatively new, 2018. Okay, so what we can say here, and well, before that, finally, the guide, the EP12, but EP12 curiously mentions about evaluation. They don't say if it is validation or verification. They are not explicit in that, and it says that it can be used with both ends. That's what it said, but it mentions that in the explanation, right? So, and what do I want to get with this? That this is not a very sound or solid ground. And in that case, in that sense, I perfectly understand your doubt. This is a kind of a soft, kind of a wet land, no? That in very particular methodologies might not be sufficiently clear. And let's understand this. This is what we have. We have to look for a way to adapt to this. And here, the only thing that we can do, the most direct thing that we can do is to look for information, essentially look for information. Be attentive to all the papers and publications that will give us the guidelines with regards to the state of the art in these topics, the topics that are of your interest, obviously, right? So as I say, here there's no way, not exact or precise or the only way. And what does propose EP12, for example? What it proposes, EP12, it proposes a mechanism that in this case, I made it like a mix. Sorry, there is another document before of that. There is an interesting document, which is the Committee's Guide 31 from the American Society of Microbiology. This Comitec Guide 31, it also has a protocol for verification and validation and methods. And it's very clear as well. It's very clear. And doing some sort of mixed, a little mix of everything. This guide, this Excel spreadsheet is done mixing both concepts, no? And it mixes LP12 and the Comitec 31 with the idea to establishing this decision curve, this graph of double enter, which in the end makes the calculations, but the calculation part fundamentally is given based on the LP12. So EP12, sorry. So we will see a little bit in what way the EP12, it's pretty easy to interpret, okay? Especially in the calculation part, because it synthesizes calculations a lot, and it uses a very easy model to understand, right? Therefore, what it's important is that we should add to this is, and at the end is the concept, right? I mean, it's, for example, useful to compare methods through samples, okay? By assuming, for example, that I have a reference method and a candidate method to be used. It's useful, for example, to verify and prove, verify a diagnostic kit which already comes validated by the manufacturer and brings sensitivity, specificity levels, predictive levels. I mean, I can prove that, but what do I need for? Well, I need samples. You can see that have confirmed diagnostic accuracy, and that maybe and that's where you can say something, doctor, well, where are these samples? These in the panels that you usually give in Latin America. There we have samples with diagnostic accuracy of the first level confirmed up to the sequencing. What better than that? So you can see, let's try to create this landscape with the elements that we have. And LP12, in my opinion, it's an excellent tool to be able to do these things. Now, it adds some details that we should take into account. So what can we do with EP12? What EP12 tells me here, it's be very careful at the beginning with the size of your sample, okay? Be careful with the size of your sample. Why? Because the sample size depends extensively on what do you want this for. You are using this in what type of studies? What are you going to use this? Are you going to do diagnosis? What are you going to do? Are you going to do detection? Are you going to do screening? Do you want to have confirmations? What do you want? So in practice, in some way, these things start getting related to each other. Now, it is you, obviously, the technicians of the first line that will have to make the decisions with regards to how to establish this criteria and when, as the doctor said, maybe a validation process, right? Maybe it will wait for a long time. Why? Because you have to get the samples with those characteristics of diagnostic accuracy you need, or how, or we need to buy panels. I don't know. I don't know if there are specific panels for that, but commercial ones, I mean, because there are many panels very popular with these characteristics, but in other areas. So I don't know if there are commercial panels to apply to this, but if there were, they have a cost. So first recommendation first, please be aware, take care with a number of samples based on what do you want the samples for, or what are you really doing, right? And then, well, through the double entry table, obviously, which in this case, for example, you can see that we have you see the reference method or testing method or the value, the assigned value to the previous diagnostic accuracy and the value obtained by the test or whatever things they have. Well, they establish the relationship of agreement, and this kind of qualifies in the typical double entry table, false negative, false positives, negatives, real false positive, which has the mathematical relations very well described here. Very well then, so what do we need to do? We will find experimental parameters. We will do this and we will find experimental parameters by ourselves through our experimentation. And these parameters will be given in the areas of sensitivity, specificity, predictive values, both positives and negatives. And there are then other elements related, for example, with the diagnostic accuracy, the prevalence, if applicable, and a concordance gap. I don't want to mention these details now because it's not applicable here, but there are some other ways to establish robustness and to be able to make decisions whether the quality of the data is sufficient or not. The quality and quantity, actually, okay? So we obtain, as you can see, we obtain values, sensitivity, specificity, predictive value, positive value, all of them in percentages. But establishing the concepts as well, understanding sensitivity, the capacity of the sensitivity of the method, if positive, all of that. So here we can add something. We can add the confidence intervals to the values of sensitivity, specificity, and predictive value. And this is the part that I want to mention and focus on now. The importance of the confidence intervals in obtaining, when you obtain the value, whether it is for the most important parameters, sensitivity, specificity, predictive value, positive and negative. Because why will these confidence intervals be useful for? Because the thing is that here we will establish a relationship that is finally described in the guide, in the CLSI, which establishes a way in which we can understand through the amplitude of the interval confidence interval generated for each one of the parameters with regards to the numbers of samples that we select or the type of samples actually that we select to run this study. So, or this test. So here we have an indirect way in which we can make decisions with regards to the quality of the decision that I will take. So I obtain my parameter, sensitivity, specificity. Parallel to that, we obtain the limits of the confidence interval, and I establish in some way, and in an intuitive manner, an interval that it's an appreciation of the interval. And the same I will do later on with the specificity, estimating the capacity of the method to show negative if the sample is not. And finally, I will establish the acceptance criteria. And here I want to stay for a minute with regards to the difference between validating and verifying. If I bring values from the validation that give me an information regarding that kit, regarding the sensitivity, specificity, and predictive values, evidently, those are the values that I will try to find in my analysis, in my experimental analysis. And I hope in this case, for example, that, and here is where we will have the importance of the reference intervals. I expect that the values of sensitivity, specificity, the predictive values, I'm talking just about them, these two, that's what they will give me, the values that will be within the interval. So it is not that I compare, I mean, I could say, hey, I got a sensitivity of 95%, but the sensitivity of the manufacturer is 91%. That's what the validation is telling me. Should I reject? In many cases, I have found that the labs reject and they try to obtain the 99%, but it's difficult for them to obtain that because the conditions are different. The quality and quantity of the samples are different. Therefore, in practice, what does CLSI contributes? It contributes with a sort of interval for acceptance of the validation parameter to be interpreted within this parameter and to be able to be interpreted in a reliable manner. And the use of these intervals have been found very rarely in protocols that I had to see in the setting of the qualitative techniques. So the appreciation of the interval, obviously, that favors me. That favors me because that allows me to work. I would need to be very presumptuous to pretend that I will achieve exactly the same specificity and sensitivity and predictive values of the manufacturer. If the manufacturer did this with the ideal conditions, it would be very difficult to think that. So I can now accept, based on this new way to establish the criterion, using the confidence intervals for each one of the panels. Therefore, in this case, for the sensitivity and specificity, I think that the value of the manufacturer that is expressed in the insert of my kit will be inside my interval, within my interval. And then we will see what happens with the width of the interval, which is a different thing.
¿Por qué? Primero, me aseguro
Okay, that's another thing because, well, first of all, I must ensure that this can be replicated for sensitivity purposes, for specificity values. This can be replicated for predictive positive and negative values. This can also be done. And here I remember my Mexican friend that he told me, oh, let's be careful with the predictive value, because you need to have a second conditioning factor for the predictive value. If the predictive value that you obtain is less than 0.95, it is useless. You cannot use it. And that's and the negative predictive value if it's less than 0.95. So therefore, of course, depending on the implication that it might have. So therefore, these are the forms in which I can somehow estimate these conditions. What do I use in those cases? I use what I already know. I'm going to skip this because I'm looking for something that I'm not finding. Here we have it. Here. Okay. Look at this. This is a modeling made by Gabriel Millerino in a presentation he made in Mexico, in which he took a simulation that is in the CP12 in the LP12 guideline, and he established the relationship between the amplitude of the acceptance interval of 95% of the different parameters, specificity, sensitivity, with regard to the number of samples required. So what's the point here? How can we interpret this? If we think that we have intervals, acceptance intervals in the order of 50 percentile points, we are working with samples in a number less than 10. But if we want an acceptance interval of 5 percentile points, which means an acceptance interval of 95 to 100%, we need to work with around 120 samples. Without this being a decision made by you. No, you will decide whether that broad interval is adequate for your purposes or not. There is not a clear reference that says how many samples should be included in that interval. What it's assumed in this simulation is that if you increase the number of samples, you will be reducing the reliable interval of the parameters, and that's something that is recommended. So therefore, there are some things that somehow need to be taken into account. My recommendation in general, to continue with the other topic, which is the characteristics of the measurement of the ISO 15189, is that we need to study the topic. For the time being, there is not just a single standard engraved in stone, because I can just say when the predictive value is declared by the manufacturer, I simply will will select the number of samples that I consider that it is adequate. I will check that the values, that the percentile values of the manufacturer fall within my acceptance interval, and I confirm that that acceptance interval is a reliable interval that provides 95% reliability, and that it is not, in quotes, too big, too large. And through the curve that is proposed by the CLSI, I can decide whether I can shorten this and how many more samples I would need for that to carry out this test. Unfortunately, I don't know that until later on. I will know that once I have presented a sample. So therefore, this is very difficult to know in advance, because I do not know what acceptance interval I will be having. So this is with regard with the values to verification and verification of qualitative techniques. This is something that is ongoing. There are several publications that are working on time. There is a lot of decisions still to be set by the operators, but guidelines that like the CLSI or the LP12 or the Australian guides, it's a very good guide to have a better knowledge of the state of the art in this technique. And what is recommended from a practical view is that you can validate what you have, that your protocols can indicate the reference upon which you are working. And sometimes this is not so evident, but references, I mean, with regard to the state of the art. Some time ago, I was working on qualitative verification that they were using as reference only the verification made by the same institution 10 or 15 years before. Well, in that case, that was not so valuable, really, because the parameters and the conditions and somehow the culture of the technique has changed in 10, 15 years. From a historical point of view, it's valid. From the modern time or from the thinking in the future, it's not a good idea. Well, now okay, let's see now. Something that is not now, with regard with the uncertainty of the measurements, is something that we like to deal with it. The laboratory needs to determine the uncertainty of the measurement for each measurement procedure, but on a qualitative aspect. Because the measurement uncertainty is a measure of error that goes together with the results. We have worked for many years. It's not that we have been validating an error or we have been quantifying an error, but we have been quantifying this in a different manner. Of course, now if this is some sort of antagonism with the concept of uncertainty, the standard asks for this uncertainty, but still this cannot be interpreted right now because physicians still do not know how to use it. So therefore, we need to achieve that the physician sector is including this based on the uncertainty. Sorry, we cannot listen.
Hello.
Sorry, we cannot listen. Sorry, we cannot listen. There is a lot of interference. I'm sorry. Please close your micros. Well, thank you. So therefore, the concept of uncertainty, somehow, it applies to the quantitative The concept of uncertainty is the group of is the accumulation of errors that have been happening in an analytical process and somehow will be part of the error measurement that will be part of this process. But the way in which this will be treated are quite varied that have not been quantitatively defined. There is a lot of models, but this is something that still, in spite of that quantitative methods have been properly determined, but there are several areas that are still in discussion. Now, what do we recommend? We recommend that based on the different models, we should take models based on experiments, not from prior experimental data. For example, there are models that calculate the uncertainties since the origins, since the original components of the analytical procedure, and there is another model which is known as the top-down. We use the second method that basically comes from the internal quality control data and also from intercomparison exercises. Well, I don't know if this is pertinent, but I just wanted to mention that presently, let's see, the work assessing the measurement uncertainty of qualitative analysis. This is a work made by a Chinese scientific. Now, this is very interesting. What do we speak? What kind of qualitative methods? Qualitative methods that also include a quantitative phase. So therefore, they propose to evaluate uncertainty in the gray area, in the area of conversion, in the area of the 17025 in order to have a negative aspect or to have a positive aspect concerning the CS, the interval 0.95. In practice, there is a PhD document made by Pablo Pereira, is a Portuguese professor, that he precisely says this measurement uncertainty in screening immunoassays in blood establishments. Also, there is another work by Pablo Pereira, diagnosis and calculation of uncertainties in VIH, in HIV final result. In spite of the fact that the qualitative area had remained somehow isolated concerning the use and the promotion of the methodology, this is not the case now. Qualitative aspect like this kind of technique, of course, it is being integrated into the determination of error in the critical decision phases. And in spite of the fact that you still are maintaining more towards the qualitative, the binary results, but it's important that you should also know that these things are being heard right now. Now, with the concerning 15189, also it's important that the lab defines its biological reference intervals. This is not a final thing because these are not intervals. It's not determining the absence or presence of the disease, but it establishes some criteria that has to do with the form in which the intervals are calculated from a population perspective. But well, as I said, this is not of practical interest for you, but I think that this is important. How the standard asks that the test procedure should be documented, and this applies to you perfectly. It says all test procedures must be documented. They should be written in a language that is commonly understood by the personnel in the laboratory, and they should be available. So therefore, we need to have exam procedures or test procedures that are written, that are supported in some media. No, it could be in a given format or in paper. It should be understood by the personnel of the laboratory. It should be in a language that is commonly understood, and also it should be available. It should be accessible to the staff. It should be demonstrated that the personnel knows where these documents are. They can have free access to these documents and they know how to use these documents. All the documents associated with the tests must be submitted to document control. Of course, all these will be part of the master lists of the revision of the review processes of the indexing process. They are part of the document control of any ISO procedure. So therefore, they need to have a control of formats of contents. They have identified who will assess them, who will check them, who will authorize them with all the validation criteria, as the case of any document control in the laboratory. But what is important is the content and the content of the document. And this content must mandatorily be included to the extent that it applies to the procedure. First of all, we need to include information such as the purpose of the exam, principle and method of the procedure used for examination. Remember that there is a difference between principle and method of the procedures. Performance characteristics that are applicable. For example, instructions for the patient preparation, the type of container and additives. All these can be referred to other documents. Maybe they're not in one single document. Necessary equipment and reagents, environmental and security controls as required by the procedure, calibration procedures, metrological traceability, calibration of the or control of the calibrators, stages of the procedure, quality control procedures, interference, principle of the procedure for calculating the results, no, with regard to the biological reference intervals, to see whenever they are quantitative. Instruction for determining quantitative results when the result is not within the measurement range, alert and or critical values when applicable, clinical laboratory interpretation if applicable, potential sources of variation and references. Well, so therefore this means that the laboratory must have sufficient precaution to consider all these aspects or the reference made to this aspect. So because maybe all of this might not be included in the procedure, but the reference should exist that say that this information can be found in another part, but the reference should be included. That of course that this applies to the analysis procedure that you are managing, and this can be traceable to the exact part where they are. And for that, the evaluation from an accreditation point of view is very, very rigorous. Well, with this, that's the end of my presentation. Thank you, Roberto. We're going to see now if there is any question. Well, William Ruiz is asking whether there is a study that will validate the use of chromatography of DVD and antigen chromatography in samples of solid cultures. Well, we can say that this kit in the insert is recommending for carrying out liquid form samples, and if they would like to use it in solid form samples for isolates to identify the tuberculosis complex, you need to make a verification. No, he corrects himself, not verification, but validation. He corrects, it's validation because the insert is recommending only the liquid form. But if you want to use it in another form, then this needs to be validated. I don't know that this has been validated for solid samples. It might be useful. Personally, I have tested and it had worked. But what happens is that what they are, sometimes they are marketing, the kit is for the liquid form, but that's what they are recommended. But if you want to change it to solid form, you need to do a validation. You need to see a search in different reference documents to see if this has been used in the past for solid form samples. Well, it has happened. It happens that since there is a kit of reagents and instruments, it's more difficult what has been achieved in other cases. For example, in some particular cases, I have a couple of references that there are some users that have asked the manufacturer whether they can standardize this with a different form. And the manufacturer validated that, sent it a matrix, and then after a given period of time, they made a validation, and then the kit now includes the two forms. But what I understand, this is associated to the instrument, and that's more complicated. Yes, that's why they are recommending the liquid medium, because that's what they are marketing. I know that Panama has this technique. This technique has been accredited in the reference lab, but what I don't remember whether this is done, I don't know if almost all the countries are using the LSD bioline that is much more economic, and they are recommending for the two methods, well, for the liquid form and the solid form. That's the only question that I have here right now, Roberto. So just to thank you once again. Now what we should do according to the agenda is to do the country presentation as we have done on the previous days. And now is the case of the supranational laboratory of Argentina. Norberto, you will be presenting this?
Sí, te escuchamos.
Bueno,
Puedes compartir la pantalla.
en eso estoy. Ahí,
Ya.
no sé si ustedes la ven.
Ya la vemos y está en modo de
Can you
presentación.
see my screen? Yes, and it is in presentation mode. You can start. Okay, thank you very much. Good afternoon, everybody. I will take 15 minutes to present our lab. As you had indicated in the presentations that you sent us, I will tell you that Argentina is located in the southern part of South America, and it borders with Uruguay, Brazil, Paraguay, Bolivia, and through the east, Chile. It has a surface of approximately 3,400,000 square meters, and it's divided into 23 provinces and the autonomous city of Buenos Aires. Here to the right, you can see that the autonomous city of Buenos Aires is located within the province of Buenos Aires, and the blue or red star, it's where our service is located. Argentina has a population, an estimated population as of July of this year of approximately 45,808,000 inhabitants. For you to have an idea of the TB situation in Argentina in 2020, the total number of cases reported to the National Program of TB Control were 10,232 cases, accounting for a rate of 22.1 per 100,000 inhabitants, and a total of cases of incident TB 9,714, out of which 93% were pulmonary cases and 80% of them were confirmed cases. Now, with regards to 2019, there was a decrease in the notification or reporting of cases of around 20%, and this was due to the pandemic, to the COVID pandemic. We can see in this graph that since 1980, the reporting of cases have been decreasing until 2013, in which there was a change in the curve, as you can see, with a little trend upwards from here. The problem, the most important problem that Argentina has, which is AMBA, that is the metropolitan area of the city of Buenos Aires, which covers the city of Buenos Aires plus 39 municipalities of the Buenos Aires province. This region has a surface or an area of 13,000 square kilometers, and it's where 35% of the total population of the country lives, but it also has 55% of all the TB cases existing in Argentina. And at the same time, it has 82% of the rifampicin resistant, 65% of the MDR cases, and 62% of the extreme resistant TB cases. The National Network of Laboratories of TB and has a pyramidal organization. In the first level, we have 702 peripheral labs, which conduct bacilloscopy, smear microscopies, an intermediate level of 26 laboratories that, apart from smear microscopy, do cultures, whether in solid medium or liquid medium, and in some cases, they also do the Schindler test, and a central level made up by two reference laboratories. One is ours, and the other one is the laboratory for TB and respiratory diseases, Emilio Coni in Santa Fe. At the central level, we do all the tests that in other levels are not carried out, but basically sensitivity tests for first and second line drugs, plus molecular methods for the detection of resistance in a rapid detection to drugs of the first and the second line. Here you can see how we have the distribution that we have in the country of the laboratories that conduct bacilloscopies or smear microscopies. Those who do, apart from the smear microscopy, they do culture in solid medium, out of which 123, 50 of them use the Ogawa method, and 32 labs that do cultures in liquid medium. For the sensitivity test, Argentina has approximately 19 laboratories that perform this test. You can see in the left, you can see the distribution of the laboratories that have a sensitivity test to isoniazid and rifampicin in solid medium. Here in the middle, you can see the labs that do sensitivity tests in liquid medium. And to your right, those labs who have gene expert. In total, it's 12 laboratories, out of which 5 of these laboratories are located in the Buenos Aires city, and 3 of them are located in the AMBA region. As for the sensitivity tests, that's one of the weaknesses that Argentina has, because we cannot do universal sensitivity tests. As you can see in this graph, from the total number of cases, new cases or relapses, only 23% of them, between 17 actually and 22% have a sensitivity test, and between those that were treated before, 29 and 32%, they have a sensitivity test. The Mycobacterium service, which is the service, is part of the National Administration of Laboratories and Institutes of Health, Dr. Malabran, that depends directly from the Ministry of Health. It is a national administration. This is made up by 5 centers, 2 offices, 1 scientific technical, another department of legal aspects, and it's made up at the same time by 7 institutes. That the one that you see in white is relatively new here. We belong to the National Institute of Infectious Diseases, the INEI, that's how it's called. In the National Institute of Infectious Disease, we have 4 departments. As you can see here, our service is the Mycobacterium service, which depends on the bacteriology service, which is part of the INEN at the same time. This is the organizational chart of our service. Currently, we are only 10 people, 4 professionals, 5 technicians, and 1 technical aide. Nowadays, at this point, we do not have any administrative support because, unfortunately, this person that was administrative support has just resigned. And we also have investigator from CONICET that doesn't belong to the state, but who works, has their working place, the working environment here at the laboratory, Dr. Noemi Sokobord. That's the name of this person. As for the responsibilities of the service, we act countrywide as the National Reference Laboratory for TB. As said before, this function is shared with INERF, Dr. Emilio Coni, that's the name. And we are also the National Reference Laboratory for Mycobacteriosis. As part of our activities, obviously, the main one is focused on the referential diagnosis of TB, and we provide technical assistance to the National Program for TB Control. Besides, we produce and distribute culture media, reagents, drugs. We do the surveillance of resistance to anti-TB drugs. We monitor the cases of mycobacteriosis. We also establish the standards and the working algorithms that will be used by the whole national network of TB labs. We also have the function for the training of human resources, not only through fellowships, but also through the courses that we provide. We validate the methods, and we also conduct the external assessment of the quality, the culture media used in the country, and we also invite the companies that trade this media to evaluate their quality. And we also provide support and provide advice on biosafety to the national network of TB labs. In the techniques that we are using for the identification of species, we use the PRA, a lateral flow immunochromatography, and sequencing, gene sequencing, MALDI-TOF as well. Gene sequencing, it's in red because for a couple of years we've been using it in order to provide molecular epidemiology. We do the RE, mirror, and we are now, we have started since a couple of years ago, we started doing the whole genome sequencing. For the sensitivity test, obviously, we have the traditional methods, basically liquid media. We have a technique for the detection of resistance to isoniazid and rifampicin. We have a in-house test that we have developed and validated in our lab. We do the sensitivity test with soft probes, even though we do not have them now. We also do the gene sequencing, and we are already working with other international projects to be able to conduct in real time the sequencing of the whole genome. And at the international level, as a supranational WHO lab, we support the network of labs in Latin America, and we are providing technical assistance to Brazil, Peru, Guyana, Paraguay, and Venezuela as well. In the test to accredit under the standards ERAM ISO 15089-2014 through the Argentinian Organization of Accreditation, and for this our results will be obtained. We are planning to accredit the gene expert and the sensitivity test to anti-TB drugs of the first and second line with the liquid medium. As the part of the probable or likely difficulties we might find, the first one is bureaucracy, right? Bureaucracy, I believe, is one of the highly likely difficulties that we might find, because you have seen what is the structure that we have. So sometimes to get something that takes a lot of time in terms of papers, documents, signatures, etc. But it is a challenge that so far we have been able to deal with. to overcome. Another difficulty is, well, the financial part. Many times we're kind of doing a balance, trying to find a balance to be able to manage the budget that we have. And sometimes it's necessary to make decisions and give priorities to some techniques instead of others. So what inputs to buy and which not buy. And the third, and which I think it's the main difficulty, as many of you have said, is the staff. Nowadays, we are in this situation. We are really in this situation. Each one of us, we have 20,000 hands, because we have to do many things at the same time. We have to multitask all the time. And I think that nowadays, this is the main concern that I have around my head because of the lack of personnel, of staff. As part of the benefits that I believe clients can perceive, it's reliability. No, the reliability is what gives the clients feel safe, they feel relaxed, they know that they will receive results from an accredited laboratory. This result is backed by the accreditation, and clients know that behind those results there is a whole process that we have been discussed during these 4 days, validation, verification, etc., etc. The benefits perceived for the laboratory, the recognition. I think the recognition, the having been able to get to an accreditation, that I think is the main benefit that the lab will have. Another benefit is the order, the organization, not only the order in our minds. We have had an experience. We were monitored in 2014 by SMILE from the United States, and then in 2015 and 2016 we were monitored by the NIH, and that was NIH. It was a formidable experience for us because it allowed us to sort out all the documents that we had disorganized at that time. No, it helped us a lot. We have created many records for the use of the equipment, records on the entrance or entry into the lab, records regarding the staff, and that has been pretty useful to really give our first big step to get to the accreditation. We have produce operational manuals, biosafety manuals, all the techniques, all the processes that we have, and that was thanks to those 3 years that we had this audit. It is true that when it stopped, everything was a little bit more relaxed after the audit, but now we are aware that in order to comprehensively improve the lab, we have to put in practice a transformation of the culture in the lab, right? And to be able to face this change process, for sure, we have to challenge the lab towards the excellence, and that excellence is what will take us to a continuous improvement. This continuous improvement is the one that we have to implement, and this is going to be given through the whole accreditation process. So I hope that this laboratory can achieve. I rely that it will that we will achieve it because of the capacity, and it will be a great possibility to accredit and to have all this. Thank you very much. Thank you, Norberto. Yes, we knew that you had some progress already made with projects, previous projects, and I think that based on what you have in this point, it would be kind of easier for you to be able to continue, and especially having this consultant now during this time that it's going to be funded. Maribel and Roberto, do you want to ask any question? Yes. First of all, I would like to clarify that the institution already have a quality management system. We have operational manuals quality manuals, guarantee manuals. So the Institute has 3 labs as well, which have been able to be accredited under the accreditation, the Argentinian accreditation body. They have accredited some techniques, and I am sure that if they were able to do it, we will also able to do it. Yes, like what they were saying. Sorry, Roberto. What today when Suli was talking about her experience, she was saying that the most difficult thing is to change the mindset of people, to achieve, to make people to get involved during these 3 years that we have had in this audit of the ANH, and the ANH looks for everything. We have managed to raise the awareness of people. Unfortunately, well, after many reasons and for many problems that we have had in later years, this pressure obliged us to be a little bit more relaxed. Now it finds us a little bit weakened in terms of stuff, but well, I think I trust that we will be able to pass this bad moment, and we will be able to get to accreditation.
Okay. Roberto?
Okay, Roberto. Well, I just want to congratulate Alberto. It was a great pleasure to see it. It's very well structured, as you have mentioned, and it's an excellent perspective in order to achieve what you are looking for. But you are right. I think that, as I said this morning to Maribel, everything depends on the institutional culture, on the people, and that's something that we need to take care of and to maintain. I mean, Maribel, you have any questions? No, no questions. No, just to congratulate. If there is any other comment, any question? Ada Campoyo, she's asking that the test that needs to be accredited on that occasion is the expert and the sensitivity test for first line and second line drugs for the automated liquid medium media. Ronaldo Leyes, no, I think that if we are in time, but we would like that based on a question that was made by a participant regarding spills that was not thoroughly covered. I would like that Maribel, maybe she can make some comments on that, on the spill response, and Maribel? No, just to share with you 5 minutes of a small comments that with regard to the spills management. Well, the first thing that the standard as such does not have a specific requirement on how this has how to manage spills. However, due to the international rules to risk management of chemicals, we need to establish a protocol, a procedure that is somehow documented as part of the management system, how the spills are managed inside the organization. The most simple step-by-step protocol is to see the evaluation of the spills, to have the necessary mechanisms for spill control, and to make the cleaning process as applicable. To design this, as part of the organization, there are several things that needs to be taken into account. First of all, and you need to have all-time the spills management kit. Here are some of the things that should be included here, and that could be more general, no? And I'm sure that every country has its own associated recommendations. What is important is that when you establish a protocol and the personal protection elements, as well as all the strategy that is behind this spill management process, you need also to be supported on the information included in the safety data sheets of the reagents that you have in your laboratory. For example, if you're using the safety sheets, you're gonna know exactly what are the risks associated to each one, to each reagent. If we look at the documents that already exist for each country, each country has a rule that it's that's applying the SGA, the in order to categorize each danger. Depending on the hazardous nature of each reagent, you will be establishing what is the best management mechanism required for each kind of spill. and also how you will be designed or how you will be purchased a spill management kit required for your lab. You need to see what are the substances that you're using, the degree of danger that they have, also if there's any danger for health or then danger to the environment. So therefore we need to be alert that the spill might happen. So therefore that is why it's so important to be careful about that. So therefore you need to establish the procedure, what is the protocol to be followed, what is the personal protection elements that have to be implemented as part of the spill management kit, and then you organize all that. And in addition, you carry out a protocol or a contingency plan. So every time that an associated event occurs. So therefore, the contingency plan that usually is structured with different contingency plans that have been designed by the organization can be, among other things, can be applied to the spills or any leaks that have to do with management of reagents. So therefore, you establish your contingency plan on a step-by-step procedure to see what happens, how would you react, who will be in charge of each activity. And once you have all these planned very well detailed, you make a simulation of the event. And it's important, and the expert recommend that you should also make an emergency plan and a recovery plan, because a spill can be something small that happens only to us, but it might have larger implications whenever the spill is much greater and it affects many more areas. So therefore, it's important that once you have approved the contingency plan, you need to evaluate whether it worked or not, whether the people knew exactly what to do, if all the materials were available, if the materials work correctly. This happens usually in the case of the sand, of the particles that are in the spill management kit, that sometimes the material work for all types of substances, but there are other materials that do not work for all of substances. That's what I wanted to share with you concerning spill management kits. And of course, this goes hand in hand with what you have established in your own local countries, the local regulations. Thank you, Maribel. Can you please share with us these slides so we can also include this for all the participants, and this can be included in the material that will be distributed to all participants. I would like to thank all of you. Lourdes, you have the floor. If you would like to say something or take the picture.
Sí, yo creo que sí. A ver
Yes.
si prenden las cámaras, Paulita.
Please, can you turn your cameras on?
A ver si somos más ahora. Muy bien. Ok, están. Aquí todavía faltan.
Okay.
Paola, ¿nos avisas? Pero hay muchos que no tienen cámara
Well,
prendida.
many of you have no camera on. For the picture, would you please turn your camera on?
Muy bien. Paola, ¿ya?
Okay, Paola.
Un minuto, por favor. Voy a la tercera pantalla.
Ya. Sí, porque la cuarta y la quinta no tenían, no se les veía. Qué bien, México tiene 4 personas.
Mexico has 4 people.
Franco también está con 3 personas. Está muy bien. Están lindas.
Okay,
Están lindas las fotos.
great. The pictures are great.
¿Nos avisas, Paola?
Please, Paola, you tell us.
Ok.
Muy bien.
Okay.
Muchas gracias.
Well,
Nos
thank
vemos
you.
mañana, entonces.
Thank you. See you tomorrow.
El último día.
No, tomorrow, our last day.
Nos
Thank
vemos.
you. See you tomorrow. Bye-bye.